So I have 3 assignments to talk about: sequencing, integrating new therapies, and the role of MRD. So we'll start with sequencing. I don't know if anyone knows sequencing what. I don't know what we're sequencing with this question here. So we've been talking a lot about the genetics of the disease today, and recognizing that the impacts that if there are specific genetic abnormalities, again, in the myeloma cell, not inherited genetics, in the myeloma cell, that can have predictive value for resistance to chemotherapy, how long your response lasts, and sometimes maybe can guide the nature of the chemotherapy that you might receive. But the issue with fish is that what happens is you actually have very specific probes that bind to the chromosomes to identify specific genetic defects. So you only get what you look for, period. And so if you minus 13, there had to be a probe for 13. And if there was something wrong with 4, you wouldn't know it unless there was a probe for 4 used. And so fish, which is extremely, extremely helpful in identifying abnormalities, only identifies the abnormalities that you are looking for. And so the question is really understanding the myeloma cell. The question is, what happens if we just sequence the whole DNA sequence of the myeloma cell? So we're sequencing the entire genetic code of the multiple myeloma cell. And there's different ways to get that sequencing done. When the whole genome project first was done, it probably cost $10 million to sequence the entire genome. Now it costs about $3,000 to sequence. And there's a couple different ways you can sequence. One is you sequence just those parts of the DNA that actually translate into proteins that operate the cell, whole exome sequencing, and then you just do the whole sequence of the gene, whole genome sequencing. What role that's going to have is really kind of unclear, because in an average myeloma patient, it's pretty easy for using whole genome sequencing to find 80 mutations on average. And it's really hard to know, are all 80 of those critical? Are 5 of them critical and 75 are bystanders? Do 2 genetic abnormalities interface with each other to cause the problems? And those are things that actually requires thousands and thousands of sequences to determine. One of the advantages of genome sequencing is that when you do the genome sequencing, you get all the information you would otherwise get from fish. And so when you do the genome sequencing, you figure out whether there are abnormalities of 13 or extra copies of 7, or those jumps of chromosomes from 4 to 14, or losses of chromosomes, as we heard from the son of the World War II veteran. And so the major barrier right now, quite frankly, to widespread is still cost. It's still more expensive today than using fish genetics. But like everything else, technology brings these costs down, and the possibility of fish actually being replaced by sequencing of the entire genetic code of the myeloma cell is actually, I think it's likely, frankly, that it'll replace, because it actually has less technical problems than fish. There are a lot of times where fish testing can be uninformative because there aren't enough plasma cells, or there are shipment issues or processing issues that are unlikely to affect genome sequencing. And obviously the real question for any patient is, well, then if we find abnormalities with the sequencing, will it identify druggable targets? Will it find genetic abnormalities that there actually can either be a drug or develop a drug that will target specific abnormalities in the genome. So this is really a largely unexplored area, but it's not out of the question in a disorder which is also a protein-producing cancer called macroglobulinemia. Sequencing of the genome identified one mutation that was common to every single patient. Every single patient, well, 90% anyway, had this abnormality. And then subsequently, it was found that there was a pill, and that this pill actually was specific for this abnormality and resulted in very deep and durable responses. And this wouldn't have been recognized without this genome sequencing. And so today, in that disease, macroglobulinemia, this genetic testing is both used for diagnosis and can be of assistance in guiding therapy. So I would say most of you, I'd be surprised, most of you would not have had whole genome sequencing because simply it just hasn't made its way into the clinic, but it still remains a very important research tool that requires ongoing investigation. And so at our organization, when you consent to a bone marrow, we'll actually ask you to sign a consent where we can have extra bone marrow, which goes into our research laboratory, both for immediate analysis as well as freezing of the bone marrow, because you never know when the next big thing's going to come along, and we'll have 1,000 frozen samples that we can thaw and immediately start answering questions. Just parenthetically, I'll just mention that there's obviously an issue about taking more bone marrow. I'll just tell you that it's our standard of care to do all of our bone marrows asleep. And so we just have an anesthesiologist present and use a concoction that's a little stronger than what you'd get for a colonoscopy, and we wake you up when the bone marrow's done. That allows us, because sometimes we'll actually take 3 or 4 tablespoons of extra bone marrow in order to preserve for our research, but people, if they're asleep, don't really mind that very much. So integrating new therapies into treatment is a real problem, because if you think about having a dozen different medications available for multiple myeloma, and let's say you decide you want to use 3, well, the number of combinations that you can have then would be 12 times 11 times 10. So over 1,000 combinations of drugs that you can sequence, and trying to decide what is the optimal treatment really can only be done in the context of trials, and that's hard to do in what is an orphan disease. I mean, multiple myeloma is an orphan disease. National Cancer Institute defines an orphan disease as under 50,000 patients per year, which we clearly qualify for. And so getting patients enrolled into clinical trials, and the United States is notably quite inferior to European countries in enrolling patients into clinical trials. Statistics are about 2% of cancer patients actually enroll into clinical trials of new therapies for multiple myeloma. And so trying to find out what the best treatment is can really be complex. And so the current regimen, your current, I think, default standard right now, again, is VRD, Velcade/bortezomib, Revlimid/lenalidomide, dexamethasone. That standard really was developed out of trials that built on just 2 drugs, Revlimid, dexamethasone, and then a trial that also 1,000 patients that compared Revlimid, Velcade, dexamethasone to just Revlimid, dexamethasone, and showed that 3 drugs were superior. Virtually every relapse trial that's ever been done shows 3 medicines are better than 2. So there's general consensus that 3 should be used. But which 3 you get depends on where you live. In Europe, you're not going to get VRD. You're probably going to get VT. The T is for thalidomide instead of Revlimid, mostly because of cost considerations. Drug availability is highly variable globally. If you go to China, for example, they don't have melphalan. period. So they do stem cell transplants, but they don't have melphalan, so they just make it up. And they use agents that are used for other types of hematologic cancer for the transplant. So availability plays a big role. Bortezomib cyclophosphamide dexamethasone, VCD, or Cybord-D, as Dr. Patel referred to it, was also a very common regimen, but then the French demonstrated, most of the breakthroughs because of the clinical trial accrual tend to come from France, Greece, and Italy, demonstrated that the VTD combination was better than the VCD. So, and since we use VRD here, that's how it actually grew and became the accepted treatment. But now, for example, Darzalex is approved. Daratumumab is approved for newly diagnosed myeloma. It's been approved for 3 different regimens. In Europe, in Spain, they use a lot of Velcade, melphalan, prednisone. Adding daratumumab showed better outcomes, so now they're using a 4-drug regimen that they have approved. And in the United States, Dara VTD is also approved, Velcade, thalidomide, dex with the Darzalex. And then finally, then Dara VRD is really where we're headed, daratumumab, Velcade, Revlimid, dex. There are serious economic considerations that occur when these new drugs come out because the nature of the pricing. Revlimid is now running about $180,000 a year. Velcade runs approximately $130,000 a year, and Darzalex, at least in the first year, in the way in which it's given weekly initially and every other week, is running close to $200,000 a year. So you add those up, and you're really $500,000 a year for every myeloma patient with induction therapy, and that becomes a serious consideration for the federal government and for state governments for those patients who are receiving Medicaid assistance. And so it's not a simple question when a new drug gets developed, is it an add-on? And so some of the questions, for example, that will require trials to answer the question. So you have Darzalex. So is the right answer going to be Darzalex, Velcade, dexamethasone, Darzalex, Revlimid, dexamethasone, or all of them, Darzalex, Velcade, Revlimid, and dexamethasone? And those things really aren't answered easily in terms of endpoints. One of the things about clinical trials, bluntly, they were very, very easy to do when I started, because the key endpoint for patients is survival. That's really what you want to know. What's going to get me to live the longest? And when multiple myeloma, CIRSA 1980 had a median survival and average survival of 2.5 to 3 years, it was pretty easy to do trials quickly to demonstrate benefit. But that's not, of course, where we are. Now we're in an era where we've got people in a room where 15 years and 20 years and 10 years is now a dime a dozen with multiple myeloma, and that's clearly only going to get better. And then the question is, well, if you're going to do a clinical trial of new drugs and integrating them, and your final answer is how long you live, well, the person who starts the trial is retired before the trial results become available. And you can say, well, still, we should adhere to that because that's the most important outcome, is survival. But while we're waiting for the results of the trial, the drug's not approved. And so patients who are not on the trial can't get it. And so they're denied access to a drug that may subsequently turn out to be very active, although you're waiting 10 years. So now there are different endpoints that are trying to be sold to the FDA to say this is a useful agent. And the first one is progression-free survival, which is just a fancy term for how long my myeloma stayed in remission. So for some trials, you can't wait 10 years for the survival answer. So what they do is they treat patients and they follow how long their myeloma remains under control before it finally progresses. And That has been an accepted and validated endpoint for the integration of these new agents. But even that's getting to be a problem because now we're seeing these types for newly diagnosed where progression-free survivals are 4 and 5 years. And so it's still taking an incredibly long time to get to the answer. And that means that patients who are not on the trial are denied access to potentially life-saving agents while we're waiting for these trials to mature. So the next step, then how can we get agents in your hands in a rapid fashion? That the next is MRD negativity. And the argument that's going to the FDA is that if a drug or a drug combination produces less than 1 myeloma cell in 1,000,000, and that's significantly better, let's say in a transplant population, 65% versus 80%, then that should also be a pathway to getting these medications into your hands. That is not a substitute, of course, for getting yourself enrolled in a clinical trial, as Jenny has referred to many times. So then will the role of MRD? What is the purpose of MRD, both for the science of myeloma as well as for you as an individual? Couple things. There are different ways to measure MRD. The two most common are sequencing, the same sequencing I started the talk out with, where you look in the bone marrow and you try to find myeloma DNA, as opposed to just the normal DNA that's found in the bone marrow. And so you can sequence to try and find that out. Not every lab is equipped to do that, and so it's not always a very simple technique to do, but it was probably the first validated technique where you just sequence the bone marrow and just say, is there myeloma DNA present and how much myeloma DNA is present? Second technique for MRD is flow. And by flow, it's a machine that actually shines light on the myeloma cells that have been specially treated to shine back if there's myeloma present. And that technique easily can detect 1 cell in 100,000, probably 1 in 1,000,000 now. And so that's probably the predominant technique that's being used currently in the United States because the machinery and the equipment really exists already in most hospital laboratories. We're currently working on a third technique for MRD, and that's actually a technique called mass spectroscopy. And I don't know what's going to end up being the winner, but mass spectroscopy. So we talked about measuring your proteins. You know, we measure the protein, the IgG and the IgA and the M spike, and we can measure the M spike down to 0.2. But what if we developed a technique that could measure the myeloma protein 1,000 times more sensitive than that, to 0.0002? Well, what would that mean? Well, that would mean that your MRD measurement would require blood, not bone marrow. And the argument would be is that if you're truly MRD negative, if there's no myeloma, then there can't be a myeloma protein. And so right now, as we talk about MRD, there's not even a global consensus about how we're going to measure it and what's going to be the best way to do it. And there's ongoing research. And of course, MRD measurements that require bone marrow, well, you're only going to be able to do that a limited number of times. We're not going to be checking it every 2 months. Where blood-based assays with ultrasensitive techniques looking for the myeloma protein to prove that the cell of origin is no longer there to produce it may be a significant alternative. But then the question comes up, okay, we've got the MRD, what are we doing with the MRD? Well, one of the reasons for MRD, as I mentioned, was rapid drug approval by the FDA. But that's not clinical decision making, that's getting a drug approved for use. That's not clinical practice. So in that circumstance, the MRD would only be relevant if the patient was on an experimental trial of a drug for myeloma to demonstrate its superiority. It doesn't do you anything. There are two key questions regarding MRD. Number one, should MRD drive the selection of your treatment? Those of you who've been through VRD, transplant, Revlimid maintenance may know your MRD status, but I'd be willing to bet that nobody's telling you that, oh, your MRD is this or that, so we need to change your treatment based on the MRD. That is not happening in clinical practice. The decision to say, oh, you still have MRD, so we need to change your treatment, we need to intensify your treatment, we need to add 2 new drugs to your treatment, that is not part of practice. And so the MRD is not currently driving decisions with regard to, have I been treated sufficiently? And so it's prognostically useful. Yes, there's no question about the fact that if you are MRD negative, on average, you'll do better than someone who's not MRD negative, but that doesn't mean that if you are MRD positive, if you haven't achieved MRD negative, that means you should have a treatment change or a treatment intensification or that your treatment has failed. There's just simply no data to suggest that. So already the MRD isn't used then for decisions about therapy. The second is that, well, what about maintenance therapy? How long should I be on maintenance therapy? Should I be on maintenance therapy for 2 years, 3 years, 5 years, or I just stay on it because I'm doing okay? And right now, based on evidence, that's not an answerable question. No one can actually, they'll tell you what they do, but they can't actually tell you what the science tells you about how long you should be on maintenance therapy. So a very legitimate question is, I'm MRD negative, do I need maintenance therapy? Or I'll back it up, do I need a transplant? Current evidence suggests that if you're MRD negative, you still benefit from a transplant. And if you're MRD negative, you still benefit from maintenance therapy. So it doesn't change that treatment paradigm. But the question then comes up, okay, I've been on Revlimid now 2 years and I'm MRD negative, can I stop the Revlimid? And the answer is, you can't answer that one either because no trial's been done, because what you'd have to do is toss the coin, half the patients stop Revlimid, half the patients continue Revlimid. And you go, whoa, who would do a trial like that? Well, in fact, in chronic myelogenous leukemia, the French did exactly that trial. They put them on treatment until they developed no molecular evidence of the disease. Then they tossed the coin, half stayed on, half stopped, and they found out that of the half that stopped, half of them could stay off it indefinitely, and the other half had to resume therapy. And we don't have that data for myeloma. So your MRD doesn't tell you what to do with maintenance currently, and it doesn't tell you what to do with induction. And so I think it's a really, really important debate, in my opinion, that patients not on clinical trials, should they actually have routine MRD testing? Dr. Patel may be willing to answer that question when we go to Q&A. At Mayo, we do the MRD testing in patients who otherwise have a complete response. But the reason we actually do it is not because the patient gets useful information, it's because we almost always will publish the information that we accrue. So it's really about the science and research that we're doing it, about outcomes in patients who are MRD positive and negative. But in terms of, okay, I'm MRD negative, okay, maybe you'll sleep better at night, or maybe you'll be MRD positive and you'll toss and turn at night. But it's just information to have that doesn't result in direct decision making. It just doesn't result in direct decision making about your management. So it's a very important thing that MRD, yeah, it really does predict people who are going to do better. Okay, so maybe you want to know for that reason. But if you're not on a clinical trial and that MRD is being used as a specific endpoint to get the drug approved, it's not so clear in my mind that even though we can do it, that we should do it because we have so many other ways to measure disease activity specific to the proteins themselves, whether the protein's stable or the protein's rising. Certainly if I had a patient who had no visible protein in the blood or in the urine and had MRD positivity in their marrow, that wouldn't cause me to make a change in treatment. In fact, even in patients where the protein's rising, and I know that they're having some relapse, if that's a slow relapse, it's not really going very quickly, I'll often observe patients. I don't feel that I'm compelled for someone who's having a relapse that's occurring over a 12 or 18-month period to instantaneously change their treatment because the light chain went from 5 to 9, which is probably a meaningful change, but that doesn't necessarily mean it's anything bad for the patient themselves. And so by this point, you're probably ready for a nap. I get that. It's really bad to talk after lunch, particularly on obscure, and there's no garden equivalent for this MRD stuff, that's for sure. You know, it's like, you know, 1 weed per acre is what we're looking for. Good luck on the hunt. But I think I'll stop with that, I think, because otherwise I think everyone will just be more perplexed.